stages will be more understanding of the role of HPV and the stages, the precancerous stages, the cervical cancer goes through before it becomes an invasive. So, the 30 years ago, the American College of Obstetrics and Gynecology and American Cancer Society were united in approaching that they would do PAP smear, annual PAP smear, till they reach 18, and with PAP smear with clinical examination. And then it's up to the physician to do it this frequent. And it was very simple up to the age of 18, being sexually active, and so on and so forth. It got different for different societies and so on and so forth, till we are, most of us now. Please, we already have got a limited number. Come, and you are coming already late. Come at the front, Doctor. And all of you, and I want the phones to be silent and focus on the presentation. So we don't, for example, in Saudi Arabia, we don't have a national screening program, so we don't really know the course of action, what's the rate of the abnormal PAP smear, etc. So we have to adopt somehow some of the international criteria or screening programs. So the ACOG, the one was in 2016, had a minor reservation afterward, is what we generally do here. With the introduction of HPV screening, and then if it's abnormal, look for PAP smear, and having the vaccination, the enthusiasm got less and less of developing a national screening program. Although we have been calling for that for the last 30 years, nothing really progressed. But anyway, so what we are adopting right now in the country, most of us, because the screening is opportunistic. If you are in King Faisal, you screen your patients. If you are in a National Guard or security forces, you have got your primary health care patients whom you are training from your population, and then you apply it. But most people will do this one. And you begin the screening at the age of 21, from 21 and you end it at 65. And you do cytology only every 3 years, and if you are accompanying it with HPV DNA testing, then you can do it every 5 years. And if you do hysterectomy, total hysterectomy with removal of the cervix, for pathology not related to the cervix, it's not recommended to do any screening. So if you remember this one, you can confidently, if you are not a obstetrician gynecologist, if you are the only physician in the family and they are asking you when and how to do PAP smear, then that's probably what you should be announcing. Now we knew whom to screen and when to screen, then how to manage. The most confusing one is ASCAS. With ASCAS, atypical squamous cells of undetermined significance, they immediately send, as a reflex cytology, they send they send for HPV DNA. When it comes negative, I see most people, they repeat after 6 months, after 1 year. Even the pathologist, they would send you the recommendation to do it. But the recommendation is just do a routine screening after 3 years, because most of these cases actually are a result from infectious process or so.
Touch screen.
If you are doing an ASCAS and then for financial reasons, or you don't have the availability of doing HPV DNA testing, which is a lot, by the way, unfortunately it's a lot. So if the ASCAS you repeat it after 1 year. And if the abnormality persisted, then you do colposcopy. I'm going to spend more time here and listen to treatment, because probably at your level that's what you're interested to know. If there is normal cytology, and it's not uncommon, you'd see PAP smear is normal, but the HPV DNA is positive for high-risk group, then you'd repeat the cytology plus HPV in 12 after a year, with colposcopy any other abnormality. And so on and so forth. When you go for ASCAS high-risk HPV positive, or HPV positive or two times, or so on and so forth, you would, so persistence of low abnormality, you would go for colposcopy. Any higher abnormality, either high grade or ASCAS cannot rule out high, which is associated with 30% high risk group, or adenocarcinoma in situ, then you do immediately colposcopy. So we have been saying, talking, the natural course of things. If abnormality persisted, you would go for colposcopy. What is a colposcope? Who attended a clinic with us? انتوا سنة كام؟
سنة
سنة رابعة. Okay. Colposcopy, simply, you can see any form. Simply, it consists of 3 items: magnifying lens, a light source, and a stent. That's a colposcope. This colposcope can be connected to a close video monitoring, can have video capturing, can have interactive screen, can have operating channels to take biopsies, etc. But a colposcope is this: a magnifying lens with light source, with a green filter to see the abnormal vessels, etc. Here I'm not going to spend much time in here, but you have it. Whoever is more interested, he can look it up. What are the indications for initial colposcopy and what to do in a later stage? So, the high risk in the past, the recommendation, and still some of the senior gynecologists or gynecologists would still do 2 things: treat, that's different, and treat with excisional biopsy. Have you ever heard about cone biopsy?
Yes.
Yeah. Cone, now we do it with lead cone. Unfortunately, it's an excellent treatment, brings you tissues, but you don't have to do it all the time for cervical abnormality. You don't have to treat low-grade cervical exchanges, because 60% of those would disappear on its own. The high-grade exchanges, that are the ones you need to treat. That's number 1. Number 2, and you treat it with what's called ablative methods. Cryocautery, you freeze it, you cool it down, etc. Because of the associated morbidity of treatment with these cones with premature delivery or premature death. واضح؟ وتدخل بعد كده في موضوع cervical circulation, etc. In the past, because we did not understand the disease very well, we were screening them more, we were treating them more, and treating them more aggressively. But now we know the course of event is very slow, takes years, and we understand the HPV mechanism and the high risk group, etc. So, as we said, excisional techniques. Excisional meaning there's two types of treatment: ablative and excisional, or destructive and excisional. Excisional is like commerce. You do it with laser, with leaf, with cautery, whatever it is, with knife. Ablative is when you destroy. Some people has got an impression that the prognosis of treating them with this way or that way is different. No, it's the same. You can treat carcinoma in situ, CIN3 with excisional or ablative. The only difference, you get histopathological specimen, which you don't need all the time, because if you think about it, you wouldn't treat anyone except with a colposcopy before, so. But you have got to have 4 conditions. In the presence of 4 conditions, you must, so treatment equal to do excisional or cone or ablative, destructive. But certain situation, you need to have cone, to do cone. Otherwise, your treatment is incomplete. I want you to understand these 4 situations. Number 1, if unsatisfactory colposcopy, meaning you cannot see the whole transformation zone. You know what you mean by transformation zone? Tell me what's transformation zone? Definition of transformation zone. هذا كله اسمه squamous columnar junction.
Yes, it's when the columnar becomes squamous.
That's from columnar junction. أنا بسأل على transformation zone.
From the sense change their
She's raising her hand. اتفضل.
When a female reaches puberty, the squamocolumnar junction changes its position. So this becomes the transitional zone.
يا سلام عليك. In more sophisticated terminology. So when she was young, the squamocolumnar junction was here, old squamocolumnar junction, صح? It got changed and went here, فهذا صار new squamocolumnar junction, صح? This area is called transformation zone. Why are we interested in this area? If you see this area, so if you see the columnar epithelium, anything more towards you, that's the transformation zone, صح? Why are we interested in it? Because this is the area which is mostly affected by the changes. لما يكون ال HPV exposure occur, the area which is more, all the area is vulnerable, vulva, vagina, cervix, all of the areas vulnerable. But the area which has got the transformation zone, or the area of metaplasia, what's metaplasia? What's metaplasia? Well,
it's changing from one cell, from one
in,
tissue.
here, in this case, changing from what to what?
It's changing from squamous to columnar.
Seriously?
Or it's sorry, the opposite. Yes, it's the columnar to squamous.
Okay.
Yeah.
It changes from columnar to squamous. So it reaches stages going from columnar to squamous. So this baby squamous epithelium is vulnerable to changes, to the oncogenic changes happens by the HPV. So when the HPV gets exposed in this area, this is the area where the virus can get integrated into the DNA of this baby squamous epithelium, and it's changing it and into a precancerous lesion. The other ones are more resilient, whether it is the columnar or the squamous. They are already matured and formed. It takes stronger, more effort to have these changes. That's why we are very interested in sampling, biopsying, cytology, evaluating this area. So when you have unsatisfactory colposcopy, all the changes are inside and you really can't see them. Once it becomes unsatisfactory colposcopy, then you need to do a cone biopsy. You need a specimen to evaluate outside, to evaluate the margins, if it's all completely removed, and to evaluate if there is cancer. So, right? Don't sleep on me, guys. So, unsatisfactory colposcopy. Number 2, positive ECC. If you can't see things, there's endocervical curate. You curate this area. If this area is curated and it is positive, then you would need to have this cone thing. 3. Microinvasive disease or microinvasive disease. If there's you can't diagnose microinvasion, which is invasion you cannot see by naked eye, up to 3 millimeter. Microinvasion you cannot see it unless you have a cone biopsy. 4. Discrepancy between cytology and pathology. Meaning, you did a PAP smear and it shows high-grade squamous enteroepithelial lesion. You did biopsies and you found low grades on it. So that means you did not sample or do the proper area. You do the colposcopy. So you PAP smear high grade, colposcopy biopsy low grade. That means you did not sample the area, the abnormal area. So if you have got one of these 4, you have to do a cone biopsy. Otherwise, both are equal. The excisional or ablative. If you understand this, that's probably the rest are additional terms. So, ablative, like cryotherapy or laser, use it if the lesion is small and completely visible. It's like a gun. Have you ever seen the cryotherapy machine? في الكتب لما بتقرا ما بتشوفوا ما بيحطوا صور حتى. طيب, okay. Anyway, so the Cryoprobe, if it applies on the lesion, then you can do it. If there is multiple lesions, probably laser is a better option. Excision, we do the loop or the cone. No one does cone anymore. I think so. Okay. If the woman had, for example, she had abnormal PAP smear or abnormal cytology high grade, and you choose to do hysterectomy, no, you don't need to do hysterectomy, but you choose to do hysterectomy because she has got abnormal bleeding, she has got fibroids, she has got adenomyosis, other conditions, then you do cytology every 3 years for 20 years after the hysterectomy done for the abnormal cone biopsy. And then if it's cryotherapy, laser ablation, loop excision, or cone with negative margins, you do cytology after 1 year, then after 2 years, and then every 3 years going to back to normal cytology. If you have got positive margins, then you repeat it after 6 months. It's important here because so many people doesn't apply on the screen. So many people take them for another cone, which is wrong if the margins are positive, because the healing process itself takes care of the margin. What is a couple of life cases probably is going to be. So we emphasize, as we said, we do less is more. Don't biopsy everyone. Don't take everyone for treatment. As long as you don't miss them, and don't give them false reassurance with that or major occurrence. Just the follow up is the most important. How do you report the PAP smear? There is something called Bethesda system. Bethesda is a city near Washington DC in the early 1990s. They met all the people interested in this field, and basically wanted to decide on a way of presenting. تعالى دكتور في كراسي كده. Supposed to start at 8. دكتورة. Come. So that's what's called Bethesda system. They aim to simplify the reporting, and everybody speaks the same language. So pathologist, gynecologist, cytopathologist, etc., etc. And it was like a mini consultation where they tell you if there is infection, if it's satisfactory or not, what's the epithelial abnormality, and tell you what to do. Okay. And then it progressed to got another 2001, 2006, like that. This is an ask us how it look like. Of course, remember one thing. Abnormal cells are got a higher nuclear cytoplasmic ratio, and the more dense the nucleus, the more chromatin, etc. It's basically the abnormality is more. So I'm going to show you more pictures. So this is the low-grade changes. You can see the nucleus is a little bit big, but not too big, and the color is dark, but not too dark. Where compared to high grade, the nuclear cytoplasmic ratio is higher, and the nucleus is smaller. And that's an adenocarcinoma inside. Why do we treat? Why do we treat? Local, we don't want it to progress to cancer, and want to local control it. And these are the different methods which we talked about it. As you can see here, all the time, the ablative methods has got less than 2% complication rate, and as you can see, that's the different methods of using. And these are the ones during pregnancy, when there's abnormal PAP smear, you do it once every 3 months, every trimester with colposcopy. You avoid endocervical curetting, and you avoid biopsy because of the bleeding, and ECC because of the bone rupture. The group leader, volunteer someone.
This is a 37-year-old woman.
with the PAP smear showing this plastic squamous antiglandular cells. She presented for colonoscopic evaluation.
So you can see well, this is the colposcopic picture, this is the cervix, goes without saying. This is the cervix, the external os, and these are the changes after applying acetic acid. What are you seeing? Answer.
So maybe bleeding or redness. There is scars.
There's 4 options. Read the options and tell me which one of them.
And those. Those three? Okay.
انت شايف ولا انت شايف؟ مالك سلامات.
Okay.
عسى ما شاء هذه are the options.
Okay.
وفي شيء مكتوب هناك على options.
Still on 64. No. It's fine.
This is describing something totally different. This is a case applying for this case. What's your name?
Han.
Huh?
Han.
Han. This is the case, and it's like an exam, and these 4 choices, like MCQ, and this is the picture. Can you read it loud, please?
Okay. A large branching T-zone vessels. B. Grade 1 acetoids with vascular changes secondary to trichomonas infection. C. Grade 2-3 acetoids with coarse mosaic and punctuation. Punctation.
Have you heard this terminology before?
Punctation, no.
Mosaic pattern. The blood vessels in the cervix goes, and any organ goes either direct or sideways, and the abnormal cells are in between. The abnormal cells, as we said, we have got high nuclear cytoplasmic ratio, so the nucleus is big. So this interlacing strategy becomes, when they are sideways, becomes like mosaic pattern, like a mosaic pattern. When it comes directly at the front, it becomes like this punctation. And the answer is grade 2 to 3 acetoide or coarse mosaic punctation. Mosaic pattern is a lot because the vessels are squeezed between these abnormal cells, and with the punctation like this, they box. Is it clear? Are you understanding what's happening?
I just want to understand the mosaic and the punctation. Yeah, what causes it?
Okay. Let us. This is normal cell, abnormal cell. Okay. Nucleus, cytoplasm. Nucleus, cytoplasm. Okay, when you put acetic acid, 5%, it dehydrates, it ruptures the membrane. So it becomes only, so if the abnormal cells are like that big, they have got 2 effects. It's a solid, abnormal it's nuclei. You rupture the cytoplasm, so it becomes a collection of nuclei. So you apply the light, and the light doesn't go through, it reflects back, it looks white. So one of the tests we see is the acetoide. Acetoide meaning the color becomes white in relation to the acetic acid application. Okay? So the whiter, the quicker it becomes white, the more distinct the borders between the white area. This becomes acetoide. It's more pathology. We are doing all of this to tell us how and from where to take your biopsy. واضحة؟ Thus, you get 2 types of blood vessels are there in every organ. الشعيرات الدموية الدقيقة. ماشي نسوي بلون ثاني. في ماشية بالشكل هذا، في ماشية كذا، في ماشية بالشكل. When it gets squeezed, it's like the hose in your garden. It's the distal part, the proximal part becomes thick. If it gets squeezed here, this becomes thicker and more obvious. So the blood vessels, if they are coming sideways and gets squeezed by this large nuclei, it will form this shape. It becomes a dilated blood vessels coming بالعرض. فهذه بنسميها الموزايك باترن، الموزايك الاسلامي، الشكل الاسلامي الموزايك. لما تكون البلاد فيسلز طالعه بالطول بالشكل هذا and it gets squeezed هتلاقيها زي الدوتس، هتتمدد وتصير زي الدوتس، فبنسموها punctation، ماشي بهذا الشكل. كل هذا دليل على you collect this information of this abnormality and then you do the direct biopsy. الهدف كله من المفتاح. Do you have any non-Arabic speaker here? The idea behind the colposcopic evaluation is to be able to identify the most pathological area which need to be biopsy. So you take your biopsy and you have a good representation of the pathology. So if we always look at it as like a clock watch, where if this is 12 o'clock, 6 o'clock, 11, where is the most likely area to represent abnormality for you in order for you to biopsy?
3. 7 maybe.
1, 2.
11 to 12. It's the
11.
whitish, the
3 and
the
9.
most whitish area.
يعني انتوا answering an exam or answering a question, it's not only science، فيها شوية ذكاء. شوف الاختيارات. اتفضل.
3 and 9.
انت وثري and 9. Who else would say?
I said C.
C, yes.
See.
Who would say C? ارفع يدك وانت قلت. C. It is C. 11 and 12. Read the comment. ما شاء الله عليك.
C2 white areas are at 11 and 12 o'clock. Representative biopsies of each colposcopic pattern should be taken. Though the colposcopic patterns are highly suggestive, predictive of the histological findings on biopsy, they are not 100% predictive. Therefore, every high-grade pattern should be biopsied. The pattern at 12 o'clock of a coarse mosaic with a central punctate is highly suggestive of carcinoma.
Okay, so this is the histology of 12 o'clock, which is highly represented. What do you think does she? I don't think you can read it if it's histology, but what do you think she has? So we were supposed to start at 8. Come, you know, so why did you come late? The proper answer, I'm sorry. Not yes, I know. It's really rubbing on a window, okay? Come up the front so you can see. Okay. Basically, this is only shows it's all lymphocytes. Did not represent. That's why the good thing to do more biopsies. For saving money, we will put them all in the same job. It's supposed to have this at 11 o'clock, it's at 12 o'clock. But here, as you can see, 12 o'clock was well representing the pathology, which involving the whole lining except the basal membrane. So it involves all the area, all these whole same thing. So based on this, what would you do? What can you do? You can exercise it back home, and you can just read in your mind quickly with your eyes wide. So you exercise it within the cone biopsy, and this is, as you can see. So tell me, what would be the proper answer? A, B, C, D. C. Oh, C. Microglandular hyperplasia. Microglandular hyperplasia with CIN. Do another case, another quick case. في الفيميل سايد فيميل. تفضل أحد يقرأ، أحد فولنتير يقرأ. قاعد لو واحد عنده مشاكل في النوم حيجي. Be interactive. يعني this is you are investing time and your parents investing money. احنا طب انت مثلا قلتي شويه تفضل دكتور.
This is an 18-year-old woman who 1 year earlier was treated for CIN2 with an electrosurgical loop excision. At that time, the disease was found to focally involve the endocervical margin. She presents for a follow-up colposcopic examination.
Okay, so this is the colposcopy of some woman. Her cervix looks weird, but this is after bone biopsy. It looks like that. Read the options and tell me the answer.
So the colposcopic findings in the slide at the right are A. Acetowhite epithelium from 6 to 11 o'clock with coarse punctuation from 6 to 9 o'clock. B. Endocervical polyps with acetowhite epithelium at the tips. C. Microglandular hyperplasia. D. Fusion of the villus tips with acetowhite change suggestive of adenocarcinoma inside. A.
Excellent. Excellent. Is everybody online?
Yes.
So where would you do your biopsies?
D.
Who said 8 and 10? Okay, do you know why?
That's the
Why
thing.
would come at the ECC in the cervical keratin?
Like to clean the area.
No. The margins had positive. Deep margins on the cervix had positive, so you have to evaluate the deep margins. يعني you have to evaluate the endocervix. The only way to evaluate the endocervix is the endocervical keratin. ايش هذا؟ Okay. Read now. Biopsies is here showing what? What is this? كويلوسايتس. ما شاء الله. انتوا يعني البيولوجيكال كلوك بتشتغل من الساعة 9؟ كنتوا نايمين ساعة فجأة صحيتوا ما شاء الله؟ ولا مستحيين ولا شو الموضوع؟ Good. الراجل كان بيسألني أقرأ من هنا ولا أقرأ من هنا بديت. Once he asked this question والله يعني خفت ساعتها قلت لا أنا داخل قاعة خطأ إحنا في ما يعني خير. Yes, coilocytes, very good. How would you characterize the coilocytes? Yes, you get me enthusiastic. How would you?
It's like there's a whitish cytoplasm. It's like it looks
Very
like
nuclear hollows, yes, yes. A big nucleus, yes, good. So what are you seeing here?
HPV.
Good, yes, and HPV show you and plus changes. How was it? So, same one.
First.
Very good. How would you treat this patient, not in general? تفضل.
No, I have a question. How is the CIN1?
How is CIN?
Yeah, that's because it's the coilocytes are taking the whole.
Coilocytes is infected cells with HPV بس التشينجز حقت السيلز مختلفة عن هذه وغيرها كانت احنا طبعا ما شفنا السلايد كلها كانت taking only 1/3. Treatment?
D.
Hmm?
Like we take the small oxygen.
Excellent. Almost all people would say C, but why D in this case? لأن already we made it already. ما صح؟
No proof.
ما yeah. Can read it. Another quick case. Okay. Who wants to volunteer? Yeah, go ahead.
The patient is 35-year-old para2002.
مش مشكلة بقى to living too.
Okay. So was referred for evaluation of cervical cytology reported as compatible with moderate dysplasia, keratinizing type HSIL. The slide at the right is a low power cyto photograph before the application of acetic acid. The findings present here are acetylwhite epithelium, coarse punctuation, atypical vessels, and leukoplakia.
What is it? What do you think?
Based on the whitish appearance, I would say leukoplakia.
Very good. Very. Most people would say acetylwhite, but we did not apply it.
The acetic acid.
That's okay. You guys are يعني للأسف التأثير يعم. يلا. Okay, look, like everybody's يعني I'm assuming when you are when there's dead silence معناها انتم مقتنعين وفاهمين وواضحة الصورة.
The
So
final-
what do you call this colposcopy? تفضل. رفعت صباعك؟
No.
بس okay. What would you call it? Satisfactory or unsatisfactory?
Unsatisfactory.
Unsatisfactory. Very good. Because you cannot see the spermoglobular junction, the entire the transformation zone, the entire spermoglobular junction. This is a slide. This is the slide of a biopsy. Is it normal, low grade, high grade, invasive cancer? هذه واضحة. مين اللي كان بيسأل على 2 third 1 third؟ إيش رأيك؟
هي invasive لأن الرايت lower there is invasion.
يا أخي أعتقد كأنه مرسوم يعني مستحيل يقول لك أوضح كأنه مرسوم بالقلم إنه ما في invasion visible membrane وكأن التشيجز واخدة كل ال 3/3 وهذا طبعا بالبيت يعني سوري. فا it's CIN free. صح؟
Right lower inner part of the picture isn't it invasion?
نو بتاتش طبعا لما بتعمل بايوبسي ما بتكون يعني بتقطع شوي بتاتش شوي لانه بتقطع شوي بس طبعا ربع magnified doesn't
It zooms in.
very good management what will you do؟
For the
هذه ما فيها يعني ما فيها question what would you do؟ انت what would you do؟
remove. Cold.
remove تبع hysterectomy surgery دي ليش؟ ها؟ ليش why did you choose to do con تعال اقرا لي اذا كنت مركز هنا ليش
عشان الأول satisfied
انا satisfactory
colposcope
كل بوست satisfactory طب مالك فين الكونفدنس مو انت الجروب ليدر القائد حقهم يعني رافع العلم حامل البيرق مالك اوكي طبعا you can do it either cone biopsy في two options two options are correct okay طبعا هذه الصور كثيرة you can see how can we measure it okay guys we have on 3 minutes break if you need to drink coffee